Hello and welcome to the Australia-Indonesia's annual PAIR Summit. So wonderful to have you joining us today. To start off, I'd like to introduce you to Dr. Eugene Sebastian, who's the Executive Director of the Australia-Indonesia Centre.
Hello and welcome to the second annual summit for the Partnership for Australia-Indonesia Research, also known as PAIR. My name is Eugene Sebastian. I am the Executive Director of the Australia-Indonesia Centre and Program Director of PAIR. I wish to firstly acknowledge and pay respects to the elders and traditional owners of the land on which our Australian partner universities stand. PAIR is the Centre's flagship, our important research program based in South Sulawesi in eastern Indonesia. PAIR is supported by the Australian government, and our partners include the provincial government, the Ministry of Transport, and the National Research and Innovation Agency. Over the next 3 days, you will hear from a range of experts, researchers, policymakers, business, and community organizations. They will address the summit's 3 areas, which is healthcare systems, protecting society, and economic recovery. These topics are based on our series of COVID-19 rapid research reports published this year. These reports are our response to the pandemic. What we did was we brought together Indonesian and Australian researchers from our 11 universities to explore the impact of the pandemic on health, society, and economy. Over the next 3 days, our experts will share their findings, lessons learned about systems and their responses. We will also hear stories about communities, their resilience, innovation, and creativity. These 3 days will be an opportunity to explore ideas and consider where do we go from here. And as close neighbors and friends, how we can recover from this crisis and prepare for future ones. I want to thank all our researchers who have been involved in this important project. Thank you to all our speakers who are joining us at this summit. And I want to acknowledge and thank our partner universities, the Indonesian government, and the Department of Foreign Affairs and Trade, who've been strongly supporting our work. I hope you enjoy our conversation today, and please join us back here on Thursday, 2nd of December, and Tuesday, the 7th of December for more. Thank you.
Thank you, Eugene. That's Dr. Eugene Sebastian, the Executive Director of the Australia-Indonesia Centre. We're very grateful that the Minister of Health for Indonesia, Pak Budi Gunadi Sadikin, is also able to send us a message. Could you please welcome Pak Budi, the Minister of Health for Indonesia.
Honorable researchers, distinguished participants, ladies and gentlemen, with great crisis comes great opportunities. And so much it is with COVID-19 pandemic. As we learn from the current pandemic, we are now in a much better position to invest into the way we respond to these health emergencies. In doing so, Indonesia has invested so much to deal with the COVID-19, devising these 4 strategies. First, detection strategies. We increase the epidemiological effort, which include testing, tracing, and tracking to keep ourselves on track of ending this pandemic. We also run genomic sequence surveillance in areas where potential spikes are identified, as well as diligently monitor the mutation trend of other SARS-CoV-2 variants. Second, therapeutic strategies. We made sure hospital beds and health human resources stands ready to serve those who need the most. As the Minister of Health, I could not be more grateful for what Indonesia health workers had given us. For this, we extended our highest attainable appreciations, though we know we could never thank them enough. Third, vaccination strategies. We made sure vaccine supply, especially in areas with high density and intense mobility, was consistent. Vaccination centers were easily accessible, and vaccination certificates were made mandatory. We also made sure that vaccination distribution to vulnerable groups, such as the elderly, were accelerated. Fourth, behavioral change strategies. In coordination with Ministry of Home Affairs, we effectively applied the 4 different levels of social mobility restriction policy. This helped control the transmission level so we could maintain the health system resiliency. Going onward, we will remain vigilant and keep enforcing the robust health protocols. This is done, among others, through improving the capability of Peduli Lindungi applications. Thanks to digital technology, its insightful analytics allow us to establish effective policies and execute cross-sectoral programs to protect our society. Ladies and gentlemen, as much as we learned from the pandemic, I sincerely hope so is our eagerness to turn this crisis into opportunities. With this, I officially launched the 2021 Annual Summit for the Partnerships for Australia-Indonesia Research. Finally, I congratulate every one of you for investing your time, spirit, and energy, making our world ready for the future health emergency. Thank you.
Thank you, Pak Budi, the Minister of Health for Indonesia, for officially opening our Pair Summit 2021. It's a great opportunity for us to have a look of the work that the researchers have been doing throughout the year. And some of the key research that the Australia-Indonesia Centre has focused on for the past year has been around COVID-19, the impact of the pandemic, and that's what we're going to discuss today. In fact, for the whole 3 days that we're holding this summit, looking at different areas of impact, what has happened and how we can move forward. And this session, as you know, because you signed up for it, is on improving health data connectivity and integration. Now, the Minister mentioned in his remarks around the importance of digital, and that's definitely come out during the pandemic. A lot of the problems around data and the most useful and efficient collection of that data became acutely clear during the pandemic, not just for Indonesia, but for any country trying to get their heads around it. But particularly in Indonesia, we're going to look at what happened and the progress that has actually been made in some areas in addressing the deficiencies. Also, how Australia and Indonesia might work together, learn from each other, and help each other to move forward so that in the future these kinds of emergencies can be better handled and that the data is handled in a way that helps everyone. Now, we are going to take questions, so don't worry, you will get a chance to put questions to our fantastic panellists. I'm going to keep the chat function off for the time being, and I will let you know when it is on so that you can pop those questions into the box. And thanks to those who've already sent through questions from our invitation. Now, as we know, the Indonesian health system struggled to provide consistent and timely data on critical COVID-19 metrics. Now, that was due to health facilities having different setups, different governments adopting their own solutions. But those problems have also created some urgency to create a better system, something that the Minister also talked about. And Indonesia is at an opportune time to put in place digital systems that can create an accessible and equitable system for all Indonesian citizens. So we're going to have a look at that. What are the next best steps to establish a healthcare system that's based on best practice, but also have a look at the research behind the report, which raises some of these critical issues. Now, I'm going to introduce just two of the panelists for a start, the two co-lead researchers of the report on the collection of data in Indonesia. They're going to take you through what they've discovered and some of their findings, and then I'm going to bring in the rest of the panel. So let me introduce to you Associate Professor Shera Kinnear, who is our COVID-19 research co-lead from the University of Melbourne. And because we are a collaborative institute that works cross-country, our other co-lead is from Indonesia, Dr. Sifiroto Ko from the Universitas Gadjah Mada. And if I could please ask these two lead researchers to take us through a short presentation of their work.
Thank you, Helen. I'm now sharing my screen to start the presentation. So thank you again, everybody. Thank you for the opportunity to take part in the Australia-Indonesia Center Pair Small Rapid Research Program last year to actually address pressing challenges caused by COVID-19 in Indonesia. And of course, it was a great pleasure to work with my colleague, Dr. Rod Dilnat, as well as academics from the universities Gadjah Mada, Safira, Anis, Guardian, and our research assistants, Lely and Leah. And we were very fortunate to be able to focus on this particular project on enhancing national health information systems through data connectivity and integration to support COVID-19 response in Indonesia. As we all know, when COVID-19 pandemic started last year, Indonesia faced major people and health issues because of the fragmented information systems. Health data are not integrated, so it was really difficult to obtain a single source of truth to help trace, detect, treat, as well as control COVID cases collaboratively across the various healthcare facilities. And therefore, health and well-being of citizens were indeed at risk. These frustrating issues motivated us to propose this project. Specifically, our project has two aims. First, we would like to understand the extent of the COVID-19 data connectivity issue in Indonesia and the key challenges faced by stakeholders because of this problem. And second, we would like to propose recommendations to improve health information systems integration in Indonesia. We did a mix of methods in our research. First, we conducted an online survey targeting the primary health centers and hospitals in Yogyakarta province. And we actually ran the survey from the 20th of October until the 20th of November, 1 month. And fortunately, we got very good response rate, which is about 73%. And this is considered very good for online survey. We received 160 responses from all the various health centers and hospitals. So thank you for their participations in our research project. Then we conducted in-depth interviews with 12 key stakeholders from provincial and district health offices, provincial and district communication and information office, as well as various healthcare facilities and the community. So we would like to explore with the current situations further and identify key challenges that stakeholders actually experience. Of course, in addition to those, we also did some observations regarding what sort of systems we used and how they actually were used to provide response and manage COVID-19 cases. As our study context, we use spatial region of Yogyakarta province, which has 4 districts and 1 municipality. The region has about 4 million population, and it has high degree of autonomy to manage the local matters, of course, apart from the 5 core responsibilities of the central government. And please note that our study was conducted just about 6 months after the pandemic started. So we should consider this as a preliminary study, just an initial assessment of what happened during those difficult period and what we could do actually to address those challenges. So I will leave the rest to Safira to explain the details of our project.
Okay. Right, thank you so much, Shara. So I will continue to share our result. We are happy to report and share our analysis focusing on the flow and the situation of data connectivity and integration in Yogyakarta. So this is our situation and context, as mentioned by Shara. So our project was conducted in the early stage of the pandemic in Indonesia, say in the first 6 months after the pandemic in 2020. So the overall number of cases started to increase. And around the final stage of our project, so a new minister was appointed. Thank you so much, Bapak Menteri, Bapak Budi Gunadisadikin, for presenting some updates in this session. So we are glad to see some positive developments in dealing with pandemic in Indonesia. So based on our result, in Yogyakarta only, we found 10 applications used to capture the data with a similar type of data collected at both provincial and national levels. This is just to show some among applications that we explored. For example, from the national level, we can see new all records and matters online, and also some local or provincial applications such as CMS, COVID Tresem, and SysKLB. Well, interestingly, these different applications collected exactly the same data. Since the application are not integrated, the staff had to enter the data for, say, demography, diagnose, or lab results into 3 to 4 different applications. Of course, this is repetitive and time-consuming and has potential to create data duplication and errors. So here we are. This is the COVID data flow that we captured. Ideally speaking, it should flow like this, simply like this. It starts with one patient, and then when the patient comes with the symptoms, then he or she needs to go either to hospitals or primary healthcare or puskesmas. Then health workers record the data to SIM-RS or SIMPUS, and both systems have been in use even prior to the pandemic. Patients in the suspected or confirmed categories then have their data entered into applications owned by the district or municipality, as well as provincial application CMS, Corona Monitoring System, which also connected to the Jogja Pass contact tracing application. When the swab test is carried out, staff enter patient data into the new all record and send the specimen to the provincial referral laboratory. Then lab staff enter the result of the examination to new all record within 2 to 3 days of the examination time. Data for monitoring the progress of patient cases will be entered into the COVID-19 application in both district and municipality or provinces. Then, while the previous slide shows the ideal flow of COVID-19 data, we found that the actual flow in Yogyakarta incorporates a messaging application, which is WhatsApp, and also cloud storage, Google Drive. Ideally speaking, each system can communicate with each other, but in the actual flow, they did not. The difference between ideal and actual is the fast communication line using WhatsApp. Why? WhatsApp is increasingly important because the provincial health office must provide daily updates on the number of tests, updates of new cases and deaths to the central government. WhatsApp is simply used for quick responses and updates. But by contrast, new all records application was sometimes difficult to access, and data from health facilities were not entered in timely manner. So there is a risk of underreporting. Transformation from the existing situation shown in the ideal scenario requires strong leadership at the national level to ensure smooth collaboration between the various public and private agencies. So based on the data that we have for such a relatively short period of time, we try to provide some recommendations. Adopt the open health information exchange, use this enterprise architecture to create a national standard, develop data protection policies, and develop the system for future needs. We try to bring this open HIE framework as a baseline of our approach for recommendation, because this framework is created by a dedicated community focusing on enterprise architecture such as business process, supporting data, application, and IT infrastructure. So we can see interoperability layers here, we can see architecture components, we can see interoperability layers, and we can see point of services. We may adopt or adapt gradually, or perhaps starting from some components first and then plan further based on our context in Indonesia. But understanding components in this framework will support, I'm sure, will support countries as they develop health information exchange to improve many things, to improve patient care, to improve public health, and also the management of health resources. As stated earlier, so our project started on the early stage of the pandemic, and then while we captured the result based on the certain period of time in 2020, of course, we are aware of several developments after the project. We really appreciate responses and efforts from Ministry of Health, and we are looking forward to having further great development. And we also witnessed the vaccination and resilience program for citizens. And we know that Digital Transformation Office was established. And Indonesia now has health transformation document for 2021 to 2024. To conclude, yes, we still have so many agenda and homework, but we can see some improvement, yes, as I said before, including Digital Transformation Office and Digital Health and Health Transformation 2021 and 2024. So this is our key points in our project. So thank you so much, and we are looking forward to having some more discussion later. Thank you.
Thank you, Safira and Shera, for sharing that. That's fantastic. And just curious to know, did you look at any of the Australian experience in your work around data collection and integration?
Yes, well, sure, we can, we saw and we considered some examples from Australia, so perhaps Shera will explain more about this one. And we learned a lot from Australian system that we explored, particularly in terms of how to manage the information and data to the reliable system that will lead to provide resilience program and activities.
In particular, I think My Health Record in Australia is really a good example of what we can do in Indonesia as well, where we actually have a centralized storage of all individuals' health information, which can be stored securely, and then we can still have control over who should have access to our individual health records. So yeah, I think that will support the interoperability of managing health data and fixing all these connectivity issues in Indonesia.
Okay, well, look, that's good to know. Thank you. Thank you both so much. And interesting that you mentioned My Health, because we're fortunate we have someone on the panel who can talk a little bit about that and also the business side of things. And I will introduce the rest of our panelists now so that you can see them and they can join in the conversation. Helping those two lead researchers is Anis Baud, who's with Universitas Gadjah Gajah Mada, sorry, as well. And it's fabulous to have Anis on the panel. He is actually doing work at the moment with different ministries around this very crucial piece of progress that has to be made. Terima kasih banyak ya Pak. Thank you for joining us. And I'd also like to introduce Jeff Parker. Sorry, Petra, maaf. Lost my screen for a minute. Petra Garetji, who's the head of Pulse Lab in Jakarta, but Petra is a friend of ours. You have seen him before joining the AIC on our webinars around using data, what's happening in Indonesia, how to use the systems better. So it's fabulous that he can join us today and bring his perspective on the work that's being done in Indonesia and also with the different ministries, particularly the Ministry of Health. And our final panelist for today is Jeff Parker, who's the chairman of the Australia-Indonesia Business Council's healthcare group. And it's wonderful to have Jeff on. He works with many Australian businesses in this field and has a strong connection to Indonesia as well, and has been working very hard to build those business and industrial alliances. So it's great to have him on the panel so that we can talk to him about that as well. Hello, Jeff, and thank you. All right, well, let's get rolling. And as I said, I will invite questions from the audience shortly, but I'd like us to go into this topic a little bit more. And perhaps, Anis, I'll start with you and then move to Petra, because you're both at the front line of some of the changes that are happening. Anis, can you tell us what sort of encouraging changes have you seen since your research was completed? Ibu Safira mentioned some, but can you give us a little bit more insight into what progress has been made or where things are at?
Yes, I think the COVID-19 situation in Indonesia that has been captured by our team, especially Safira led by Sarah, has emphasized the chaotic situation during the first month of pandemics. And I think it was a good opportunity for our country, and also I think all countries in the globe to learn. And this situation bring changes, a big change in our situation. Safira mentioned a new minister came to the Ministry of Health with a strong background on different aspects, non-health sector background. And he also experienced in the chaotic situation during the financial crisis at the time, 1998. At the time, he was also in the banking economic sector. I think he learned a lot about how to improve the situation. And soon after he took the position, he developed a new office called Digital Transformation Office. And I think it is the third office at the ministries after the Ministry of Education and the Ministry of Finance that developed a new transformation, digital transformation office at the Ministry of Health, and working together with Center for Health Data. And I think this unit with strong leadership and finally developed several roadmap strategies and roadmap for integration. There are 3 components, including the integration of data, integration of application, and finally they develop to support the digital ecosystem. And I think it is a good start. And given the coming getting lower and lower COVID-19, it's a good start to improve and scale up the system, not only for the COVID-19 specific data collection, but also for other data collection in health sector. Thank you, Helen.
Okay, that is a lot. Yeah, and I think we're going to come back and have a look at some of those things that you've mentioned, because clearly a lot has been going on. But Petra, if I can go to you, perhaps a big picture of the problem that you've been looking at and where there has been some progress.
Thanks, Helen. And just if you remember last year, what we were talking about was a big picture on what we were seeing in terms of consistency on reporting of cases, and how there was a huge variance between different provinces and how they were effectively or perhaps less effectively reporting on COVID cases. So I feel that this is this continues from that conversation we had a year ago, I guess, and where the research team has gone into much more detail on the ground, looking at the issues around interoperability and consistency in data collection and systems requiring that were underlying the issues that we could see from a bird's eye perspective on why provinces were being inconsistent in the reporting of data. We're working currently now with the digital transformation officers, Panellists was saying, in undertaking a research dive with some of the counterparts in the Ministry of Health to look at how to combine also big data in some of the analysis, but looking specifically on three aspects of what are the trends in epidemiology, some of the breakthroughs due to the spread of vaccines, and then also what is the impact of some of the public intervention. So as Panellists was saying, also I feel there's been huge changes, and referring to what the minister was saying also, that with big crisis or great crisis, there's also great opportunities. I really feel the Ministry of Health is picking up on those opportunities and pushing forward, Helen.
That's good to hear. Yes, especially as you mentioned from last year, there was a lot of trouble with that collection, and clearly there is a case for change and there is a desire for change. Jeff, I saw you nodding when Anis was talking about some of the things that are being pursued. I guess that you've seen something similar in Australia and with the companies that you work with around answering some of these big questions.
Thanks, Helen. Yes, that's correct. And in effect, I'm wearing two hats today. One is as the chairman of the Australia-Indonesia Business Council Healthcare Group, as you mentioned, and we're a group of 60-odd people and 30+ organisations that have some capability in these areas. And the other hat is as an owner and leader of a healthcare consulting company that specialises in digital, with a lot of experience over the years, 20+ in looking at these dimensions. So yes, Australia's had some attempts, three, at connecting up the healthcare system. And I guess some important aspects is that the data side of things is critical to get right. It's the oil in the engine, if you like, is one way of looking at it, or the petrol. There's lots of things that can be done that need to be done. Standards is a key part of addressing that picture. And I can talk a bit more about those aspects later if you like as well.
Okay, all right. Well, let's go in and look at some of those gaps. Firstly, Safira, you mentioned them, and I think it's really interesting that there was the unreliable data, the fragmented systems, and the duplication causing people to actually use WhatsApp as a way to solve their problems. Do you feel that this is just a temporary workaround, but in a way also showed and kind of pushed along the idea that we need to do better in Indonesia and created this need to find better solutions?
Yeah, that's very true, because when we observe in the early stage of our project, we understood that they use like more than one health information system or applications, and then because when we observe that they didn't communicate each other, the system, then we try to understand more and how they can just communicate among the system. And then they said like through the WhatsApp. So this is very informal, but we found this is very a quick response, because the demand of having the data updates is very high. And yes, because we realized that this is because perhaps of the decentralization system in Yogyakarta. Yes, and then after that we summarize our finding into some reasons or some aspect that need to be considered important why the data is not reliable. So because more than one's application, so that's why we need some kind of like concept to get a better system, and the data entry and also human resource that handling that kind of data entry is also considered important factor. So yes, but the WhatsApp thing is we found very interesting, and we found this is help them to get the quick update through the system.
Probably no surprise really in a country like Indonesia, known for its adaptability and so many civil groups working during COVID to get information out there using whatever digital means was available. One of the challenges, as you've raised, just the fact that you've studied the Yogyakarta province alone, is that individual governments make their own decisions. And Petra, I'd be curious to know, are you seeing also not just a push for data integration, but an understanding amongst governments that they have to work together better, or is this one of the challenges of the moment?
Well, I was just taking note of what the Minister of Health was saying this earlier, that working around the social interventions, close collaboration between Ministry of Health and Ministry of Home Affairs. So that's one great example where ministries are working together to address the issues, and I think it points out to the there's a huge disparities between capacities and other underlying contexts in different districts and different provinces. I feel that's one aspect that you need to see where some districts have been very effective and in pushing forward different interventions, but then there's also other districts that are struggling also because of the fiscal capacity within the district. So still a huge variety, I'd say, Helen, in looking at how to address issues such as COVID. And so I guess the question back to us is, there's certain conditions where we're being able to recommend in Jogja, but are this similar necessary underlying conditions also available in other districts in terms of connectivity, for instance? I thought I'd just in thinking about what we're recommending, are there the underlying capacities as well as connectivity available for systems to be able to operate effectively across the archipelago?
That's a good point. I might go to Jeff to look at that, because obviously that's a consideration if a business is thinking about what do I set up, how do I set it up. I'm very interested too in the systems discussion, so I'll go back to Anish shortly, and then share it, change management. We need to talk to you about that. But Jeff, from a business perspective and hearing all of that, what do you think? How does business fit in? There's so many moving parts.
Well, thanks, Helen. You've actually just taken the words out of my mouth. Healthcare is complicated. There's lots of moving parts. There's lots of vested interests. And sometimes things that might appear to be sensible and the right thing to do, cause confusion and sometimes some disadvantage to other parts of the system as well. So it is complicated. And I think to a certain extent, thinking of it as a system in that it's fully organised and structured and operates in a predetermined way isn't necessarily the case. And healthcare is more like an ecosystem. We're a bit organic, if you like. And Petra touched on the challenges to do with different levels of government. Of course, we've got the private sector playing an important role, and more so in Indonesia than in Australia, with the hospitals and the medical centres and labs and so forth. So I think there's lots of opportunity. There's lots of capability that can be brought to bear, experience, lessons, etc., that could certainly assist Indonesia with its endeavours, I think.
Where does something like the example of the system in Australia called My Health, which is a centralised database, would something like that work, and what lessons have been learned from that could perhaps help make something in Indonesia, you create something better, for instance?
Thanks, Ellen. Yeah, it's a vexed question.
Sorry, Jeff.
No, that's okay. There's this current solution, or framework, if you like, that we're implementing in Australia is the third attempt. It's hard work to get a national approach to these sorts of things designed, accepted, all the stakeholders funded, implemented, and then importantly used for beneficial outcomes. So, and there's certainly some lessons from Australia's experience that could be brought to bear for Indonesia. I think in terms of the My Health Record, the original design for it was different to what was actually implemented. And along the way, sometimes changes or even compromises might need to be made to suit certain needs that emerge during the process. And it is handy having a central repository of key data, which the My Health Record is. But it doesn't give full utility to the clinical purposes, if you like, that are necessary at the point of care in all circumstances. So the Australian government, through the Australian Digital Health Agency, has embarked on a API gateway project, which effectively will be opening up access to the data and to the system as well, to make it more like an ecosystem with greater points of connectivity. So yeah, in fact, I've prepared a list of lessons which we can go through later if you like, in the broader context, but those might just do for the moment about the My Health Record that you asked about.
Yeah, it's just trying to give people a bit of an idea of the scale of what we're talking about here. So thank you. Time we have. And yes, thank you for answering the question, Panellists, in the Q&A. And yes, the Q&A is open, so send your questions. You had a very specific research question in there. I'm trying to ask this question so we don't go too deep into the technicalities, but still understand the challenge that is faced. One of the recommendations in the report was around an open HIE system, as it's called, and then you have to think about all the bits that plug into that. What perhaps one or two examples of the things that you're trying to solve, Anis, in the meetings that you're having?
Yeah, thank you, Helen. I think the issue of this integrated system between actors in the province and district actually happen not only for the COVID-19 or specific situation during pandemic, but it happens as well for other examples. For example, reporting system for non-communicable diseases, and also reporting system for any communicable diseases. So for example, tuberculosis, HIV, and others. The issue of different actors in health sector, like Jeff mentioned, the complexity of health system in Indonesia. We have primary care. We have also secondary care. And in secondary care, we have type D, C, B, and A hospital with a different level of services and technologies. So the issue of connecting data from primary care into the secondary care, it's always complicated. The coming of BPJS Kesehatan, the Jaminan Kesehatan Nasional, is actually one of the examples to improve the connectivity between different actors. Right now, for example, using BPJS system, the data with the national ID and membership of BPJS, data could be connected from primary care to secondary care. But still, it is only for those who are the member of BPJS Kesehatan. Right now, still remaining about 20% of our population are not covered by BPJS Kesehatan. So it is still an issue on how to integrate the all population data in our country. Secondly, there are also another example, for example, on tuberculosis. In tuberculosis, we focus on primary care, in which tuberculosis patient in Puskesmas, once they could not be cured in Puskesmas level and becoming the MDR or multi-drug resistant TB to be treated in the hospital, data usually are not connected. So last year, before the pandemic, actually, Ministry of Health tried to connect the TB information system in primary care and secondary care using API. So what I mentioned, OpenHIE, based on the web services system, connecting from all actors, not only on the specific disease program, but also to connect with the logistic, to connect with the registry of human resources, to connect with the registry of healthcare services is a very important. The role of interoperability layer in this kind of aspect, the Ministry of Informatics is a very important. Ministry of Informatics is right now is preparing a draft of presidential regulation on architecture of e-government system. I think we are waiting for this standard architecture that could be used later on by all players in health sector, so that the complexity that has been mentioned by Jeff could be a better ease, and we will have a more accessible system, and also to support the a more quality-based system in our health system. Thank you, Helen.
Thanks so much for that detailed answer. I appreciate that. Jeff, I see you nodding. You've got some thoughts around how business looks at this wonderfully complex question.
Thanks, Helen. Yes, not only from the business point of view, but also just based on experience, you know, and Panellists is right that an architected approach is the right way to go with that, and a part of the standards and ways of testing conformance to the standards. And there's different standards at different levels. There's data standards, which we've been talking about. There's connectivity standards and a whole range of others as well that are really key to look at. And in my experience, it's good to, when you have an architected approach, probably not to lead too early with a specific framework as a recommended solution. Those things I find usually evolve out of the conversation and the developments that the different parties have. I'm not saying open IHE is bad, it's a good framework, but the process of matching that to requirements in a very sort of detailed and thorough way is an important steps that need to be taken, I think. So yeah, thanks, Helen.
Thank you. But Petra?
Yeah, I just wanted to pick up on one of by Jeff's points when Jeff was saying, you know, how it's developed is if you look at it as an ecosystem, right? And because different systems have developed during different periods, and it's really looking at the health of this ecosystem, the interconnectivity, and in a sense, the flow of the data and information, which actually marks the strength or the health of this ecosystem. Mm-hmm. I just wanted to pick up on that particular point. Thanks, Helen.
No, that's great. Thank you. We've got roughly 10 minutes left, and I really wanted to make sure that we looked at change management and the political will to change, because, you know, you can have the greatest solution in the world, but if people don't adopt it, it's going nowhere fast. And Shara, this is your particular field of interest. We're looking at a great moment of opportunity for the Indonesian healthcare system, but we can see from the conversation and from the work you've done how many different agendas are at play, how many different ways of thinking about how to tackle this problem. So from a change management point of view, where do you start? What did your research uncover that you think provides some clues in that area?
Very interesting question, Helen. Yeah, as other typical, systems implementation, I think we have to remember that technology or the technical aspects is just, about 20-30% of the effort required to make a change, but the rest would come from the change management effort, because the people aspect is basically the most difficult and challenging way to address when we try to introduce something new systems, new ways of doing things. Since we people tend to resist any change, right? We like the way we do things, we like the system we not usually do or use, every day in our work. So naturally, we will be very protective of our status quo and would be very reluctant to change. So one of the ways perhaps in addressing this potential issue is making sure that the key stakeholders are involved early enough in any project planning or any change or vision to change something major, especially for the scale that we are talking about here at the moment, looking at the national enterprise architecture for the health ecosystem. All this will be eventually a major transformation for all stakeholders in the health ecosystem. So yeah, we just need to make sure we raise the awareness of why we need such a change and involve all the key stakeholders so early enough in the design, having consultation regularly so that they feel sense of ownership, as well as providing enough resources to implement, to train the employees, the health workers, so that they are ready and be willing to actually accept and use the system when they're ready.
Okay. And Jeff, you'd like to say something? And I'm pretty sure Pat Petra has got some thoughts on this.
Thanks, Helen. I completely agree with what was said, and change management, major piece of the puzzle. Of course, before we get to change management, we've got a case for change, and you alluded to this earlier, Helen, about what can build that. And related to that is a clear idea of the benefits that would come from whatever thing you're looking at doing, whether that's a national approach, whether it's a data integration, whatever it is. And then, of course, leading to that, or from that, is a business case, because there's serious money that needs to be applied to this. And it's until we get the buy-in from the stakeholders, and importantly, the funders being a type of stakeholder here, the government usually, and acceptance to the investment, and then an expectation of the benefits to the system, to the patients, to the providers, etc. We won't get the traction to actually make it happen. So, and having been involved each of those 3 times I mentioned in building the business cases, there's a tendency sometimes for some parties to overstate benefits and understate the change impact. And I'd just recommend a good, honest approach to this. There's no need to overstate benefits and to build a business case that's implausible. These things can be developed, and but importantly, bring the key stakeholders on the journey.
Thanks, Jeff. Petra?
Thanks, Helen. I think there's 2 points that I'd like to touch upon. Is one, with regard to these systems, that it does point out for the need for increasingly stronger competence within ministries and other government agencies, and that also links with different skill sets that are now required to be able to operationalize, adapt, adopt different systems as well. So this whole transformation requires a very systematic, let's say, the terms really causes nightmares, but bureaucratic reform, basically. So that's one point. The other point I thought, and why this is so strategic, that with PAIR working together across Indonesian and Australian universities, is also the influence of universities themselves, particularly like Gajah Mada, the advocacy capacity it has, the networks, the alumni it has. How is this used also to in really bringing to light results of research such as this that can also moving from community of practices to community of influence, communities of influence per se, where and so I think this is a side benefit that really needs to be emphasized in why partnerships such as PAIR is so important, is actually in building communities of influence to support the change process, Helen.
Thanks so much, Pak Petra. Yeah, good point. And Musafir or Pak Anies, if you'd like to comment on the work you've done is important, and how can we take it further so that it helps with policy making decisions? I think the skills thing's also very, very relevant as well, because we might not just be talking about systems and solutions, but human capacity. And that came out in the researchers' report, how critical it was to increase human capacity. Yeah, Pak Anis.
Yeah, I think thank you, Helen, and I just would like to add interesting point from Pak Petra. Indonesia has started decentralization policy since 2000, but after that, I think we need also to include the more participation and influence from the local. When Pak Petra mentioned Gajah Mada, Gajah Mada is, I think, rather unique because many staff of Gajah Mada is very close in the central level. Some also becoming the ministers in the current government. But many universities in the province and in the districts, I think that will be very important to be part of the health system improvement in the local level. We know 34 provinces in Indonesia. It is sometimes is very different to Yogyakarta. Our research in Yogyakarta is probably very different to Gorontalo, for example. So the importance of community of influence is very important, so that hopefully that next time PER could also how to provide any support from those in not only in Java but also in other, to understand how complexity of Indonesia and how to support also the business, the ecosystem, not only in Java but also in other. So the collaboration, the business, and also the current government try to improve more investment as well. I think that will be important to bring not also the local government, the universities, the academic in the local government, but also with the support on the changing in the regulatory perspective in the national level. We always support the government, the Ministry of Health, how to bring the startup, many health tech, many startup working in the health tech, and they do not receive currently well support on how to bring the innovation to come into the bureaucratic system. Just by today, the Ministry of Health started the regulatory sandbox for health tech to support a special program. But this regulatory sandbox is also very important for other aspect in the health technologies, like what has been done by OJK and Bank Indonesia on regulatory sandbox for fintech. So I think more collaboration is very important in the after pandemic. Thank you, Helen.
That's a really good point. Thank you. And yeah, Bu Safir, I'll go to you now, and then just a quick wrap up from Jeff, because I just think that the whole thing around the entrepreneurship, the creation of different businesses, let's go into that. But Safira, what would you like to add?
Just like a very quick response from Pak Petra and Pak Anis. Yes, it's very true. And I just add about community empowerment, because community empowerment is a key, can be a key. Indonesian people are communal in nature, and they tend to trust community prominent figures. So that's why empowering society through collaborations, like Pak Anis and Pak Petra said, with community leaders is a key to success in perhaps in any movement or programs. Thank you.
It's a very good point. Thank you. Yes. We are running out of time, but I would just like to get Jeff to weigh into this idea around collaboration. Incredible dynamic startups in Indonesia, lots of very smart people trying to find solutions. Can Australian business work with that? Because sometimes it feels like they're worlds apart, Jeff.
Yeah, thanks, Helen. Actually, there's already a very strong relationship between Indonesia and Australia, including in this health industry space. I might just mention, I'm friends with Dr. Bimo, and the Health Tech ID group is a representative group of the startup ecosystem in Indonesia, very, very active and doing great stuff. Dr. Hans Wijaya in Surabaya has relationships with a number of Australian vendors, if you like, in the digital space. And of course, the Australian Council on Healthcare Standards is now offering an accreditation scheme in Australia for hospital accreditation. So there's a wide range of capability, I guess, that could be brought to bear to assist Indonesia with its transformation objectives. Happy to help.
And they would learn a lot as well, I expect, in that if they were in that space too.
Actually, and I think Australia would have a lot to learn too from Indonesia.
Yeah, sorry, that's what I meant.
Yeah.
Well, that's the whole idea of this conversation, is we can work together more. We have a lot to learn. We can help each other out, but also make some fantastic progression. So unfortunately, that's where we have to leave the conversation. I'm so disappointed. There's so much more we could discuss. But thank you very much to the panelists for their time and their thoughts on the issue around data integration in the healthcare system in Indonesia. I'd like to remind you that our wonderful panelists have been Shera Kania from the University of Melbourne, Safira Koi from the Universitas Gadjah Mada, I keep saying that wrong, I'm so sorry. Pak Anis Ford from Universitas Gadjah Mada as well, and they are the research team who've been presenting to you. We've also had Pak Petra Karechi, Head of Pulse Lab in Jakarta, and Jeff Parker, the Chairman of the AIBC Healthcare Group. Thank you again for your time. That is so much appreciated. And we have been taking some questions. If you have any further questions, just send them to us and I'm sure we can pass them on. There's been some quite in-depth researcher questions, which I was not going to answer, but luckily the researchers did for us. All right, well, we're going to take a short break now and give you a chance to grab a cup of tea or coffee or a glass of water, stretch your legs a bit. But please be back here in, say, 8 minutes' time, and we'll have our next session, which is going to look at protecting healthcare workers and changing public attitudes during a crisis. The crisis, of course, being the coronavirus pandemic. I will see you in about 8 minutes. Thank you. Hello, and thanks for joining us for our second session today for the PAIR Summit by the Australia-Indonesia Centre. It's great to have your company. If you joined us earlier, you would have heard we had a great conversation around data in the healthcare system and the efforts being made to better integrate the data in a very big country so that things like the COVID-19 pandemic can be better handled. Now we're going to move on from that topic and look at how to protect healthcare workers and also change public attitudes around that during a crisis. These are two important subject areas around health messaging and how that messaging can have a serious impact on the health system. The chat function is off for the time being, or the Q&A, but we will give you an opportunity to ask questions during the discussion a little bit later, and I will let you know. And thanks to those who have already sent through questions following our invitation. Now, much has been said and written about the grueling environment that Indonesia's healthcare workers have had to live with. And this discussion is going to provide a detailed look at that situation, what they've faced, the lack of resources and how that has affected them, the kinds of decisions they've had to make on a daily basis around their safety and the information gaps. We'll also look at what is needed in the public sphere to decrease infection rates, not just amongst the public, but of course amongst frontline healthcare workers, because it carries through. How can people be motivated to follow rules and protocols that affect their health and safety? And how critical is government and official trust in all this? And we know that while there have been problems, there have also been lots of efforts to make a change. And we want to pick up on those and look at how to strengthen those responses. What I would like to do to give you just a very short snippet of an idea of what some healthcare workers have been facing is show you a video in a moment. This is where we spoke to one of the AIC senior fellows, Dr. Kristiyogo Sumatono, earlier this year about his working situation. Now, Dr. Chris is a lecturer and anaesthetist at Universitas Airlangga, and he also works at a local hospital in Surabaya. During COVID-19, he also worked at a field hospital set up to manage COVID-infected patients. It is a 300-bed facility, and Dr. Chris has been working on the front line since March 2020. So an incredible effort, and this short video is going to give you an idea of some of the things he was facing every day. I'll just let you have a listen and a watch.
Rata-rata kami kurang lebih hampir 18 sampai 20 jam. Jadi kami bisa istirahat 4 jam sampai 6 jam di rumah, kemudian berangkat lagi di tempat kerja kami.
Right, and I promised it was short. We were lucky to catch him in between one of his shifts, as you could see. So to talk about this and the issue around messaging, I'm going to introduce my panelists. I should quickly mention, of course, we have some fabulous translators with us at the moment as well. For those who are hard of hearing, we have Pak Widodo and Sophie. My apologies if I have that wrong. And also Laguna is providing an interpretation service. So you can listen to this in the language of English or Indonesian if you wish. And thank you very much to our hardworking partners for all their efforts. We do appreciate it. Let me introduce to you now our wonderful panel. Daniel Prayogo is from Monash University and is a co-lead on the research report that was done for PAIR, the Partnership for Australia-Indonesia Research, on how COVID-19 was affecting the healthcare workers. We also have as his co-lead, apologies for this work, Dr. Ratna Sari Dewi from the Institute Technology 10 November, also she's joining us from Indonesia actually, which is fantastic. Terima kasih ya Bu Ratna for joining us today. And then to talk about the work on public attitudes, please welcome Associate Professor Ansariadi Ancha, my apologies, from Universitas Hasanuddin. And he worked with Simon Reid from the University of Queensland. Thank you. Associate Professor Simon Reid from the University of Queensland will also be joining us. So as you can see, we have some very, very good speakers again. These are two research teams that have been working with the Australia-Indonesia Centre across Indonesia and Australia, working on these issues. What I think I will do is at the start just break it up into looking at the healthcare workers and their situation, and then we'll look more specifically at the healthcare messaging, and then we'll bring those two things together. So let's perhaps go to Pak Daniel and Ibu Ratna first. And before we go into your research, you just show that short that short video with our friend, Dr. Chris. I'm guessing that what he is going through does not surprise you based on your research. Bu Ratna, mungkin if you could go first.
Yes, thank you very much, Helen. Yes, it's definitely what Pak Chris mentioned in the video is what we also found in our study. So the medical workers, either this is the nurse or the doctors or other healthcare officers, they need to work very, very hard, particularly during the crisis when the number of people admitted to the hospital is pretty high. So it's it's very saddening situation. It's very, we can say it's serious situations, and it's not easy for all the medical workers and other supporting staff. Maybe Pak Daniel will add more.
Thank you, Bu Ratna, and thank you, Helen, for the questions. I think there are a number of factors that important, the key factors important that we need to understand, and that those are something that we found from our studies that involve 23 respondents from a different it's called the group of healthcare workers, including hospital directors, doctors, nurses, non-medical staff, and also epidemiologists. We also happen to be able to examine the the fight and struggles of these healthcare workers from different hospital classes, from class A, which is the top class, until class D. And we found that there are a number of factors. Number one is that in general, the policy for occupational health and safety actually has been set quite well at the national level. For example, we already have since 2016, the Minister of Health has issued the occupational health safety policy for all health facilities in Indonesia. But since July 2020, after the pandemic started, actually government has added special policy guidelines to handling the pandemics, and it's gone through 5 revisions that we have still used until now. Going to the hospitals, each hospital already established their policies. So the policy is already there. Not only that, they also provide, or they also set up what is called special prevention and treatment unit. Okay, so a group of people who have been given a task to make sure that the procedure, the policy of healthcare, of health and safety in the hospital will be adhered to by staff and implemented properly. And they also provide the facilities. For example, in some of these hospitals, they provided what is called special isolation room. So they really separate between the COVID-19 treatment area and non-COVID-19 patients area. So I would say that our findings suggest that at the policy level, Indonesian hospital has established an adequate policy and guidelines. The problem, of course, in the implementation. And there are a number of issues. Number one is, I think the most important one is the discrepancies between different hospitals. And this is very important because this discrepancy between hospitals actually affect the number of or the risk that the staff can be exposed to the infection of the COVID-19. I give 3 different examples of the discrepancies. Number one is difference of facilities. As I mentioned, at the Class A hospital, they have a special isolation room, but not every hospital has that. So the lower classes, they don't have it. Even some hospital, they only divide it between COVID and non-COVID area with only with a curtain. So it is very different from different classes hospital. Number 2 is the provision of the personal protection equipment. In one hospital, they're proud to say that all staff have been fully provided by all PPEs. But in other hospital, staff have to purchase their own PPE. And when they can't afford to do so, they have to reuse some PPEs that's supposed to be disposable. So this is the second example. Of course, the third one is the treatment of the staff who get infected by the COVID-19. Some hospitals, they provide the facilities to treat the staff who are getting infected, but others, they just have to self-isolate at home and fight for themselves. So this is the key factors that needs to be addressed. And the second one is, of course, so yeah.
Yes, no, go on. I jumped in ahead of you.
Yeah, the second one is, of course, the adherence and the awareness adherence of the staff, the obedience of the staff. And this is what we also found, that in the beginning of the pandemic, many staff actually didn't really follow the rules, and that's why the infections start to rise among the staff. And when they start to see that COVID-19 is quote unquote real, okay, it's not something that that people just talk about it, and they start to adhere to stuff to the regulation. So that is the main issues that we need to address here.
Great, because and I'm glad you mentioned that. And that's why I was jumping in, but Daniel, and I'm sorry, because I think this is the really interesting bit is around the compliance, the staff, what messages they were getting. The hospitals had policy, but how well were they implemented? Ibu Ratna, I'm wondering if you could tell us a bit more about that, please.
Yeah, about the staff compliance. Yeah, as Daniel mentioned, that actually the compliance is kind of fluctuated based on where it start with the pandemic. Maybe as common people in the society, they still don't aware about the potential risks. Probably in the same time, that's the same as what medical workers face or feel. They start with the ignorance, but after the number of people get admitted, surge, then they said, okay, this is this kind of serious. We need to really take care seriously about all the procedures, all the health protocol, considering about the high potential risk of COVID-19 infections. And later on, when the now it's become more, I think more and more more of the medical staff more conscious about the potential risk, but now there is another challenge: how to maintain the adherence and awareness to become still in the high levels, because when you are getting used to with that kind of situations, that's probably there is a chance that you become not that aware anymore. So it's a very it's kind of very you need to be consistent. I mean, the hospital management need to be consistently remind all the medical workers that work in the hospital to always pay attention about the health protocol in order to reduce the potential risk of COVID-19 infections among them.
Yeah. Thank you. That's, and I know you've got a lot more that we can talk about the work you're doing, and I will come back to that. But I'd just like to pick up on this point around the messaging, because it's obviously playing a critical role in compliance and helping to prevent the spread. I'd like to bring in our other two panelists, Ansariadi and Simon Reid. Interesting that the healthcare workers, what prompted them into realising they needed to follow these measures was seeing firsthand the effect of COVID-19 on people. Your research wasn't specifically about healthcare workers, but just looking at public compliance generally in South Sulawesi and Jakarta. Does what you're hearing from the research on healthcare workers ring true with what you have discovered? Perhaps Ansariadi, to you first, and then to you, Simon.
Yes, our study actually focused on the looking at the uptaking of preventive measure for the COVID-19. For instance, looking at the wearing masks in the public places, the willingness to uptake vaccinations, and then also risk perceptions to the COVID-19s. Previously, we heard about the COVID-19 among the health workers, particularly among the doctors. We do know that there are a lot of doctors actually get infected when they are work, but what we don't know actually where they get the infections, which is a critical question, because if we want to do some preventive measure, we really actually need to know where they get infection, whether they are during they treat the patients, because we don't know they are wearing the preventive equipments, or where they provide services from other places, for instance, during the outpatients in the clinics or in the other activities. Unfortunately, we don't have any much information on this matter, where actually the doctor get infection. We don't know that the doctor get infection, but where, because this is very important. We want to do preventive measure in the future. And regarding to our result of the study we conducted in Jakarta and in Makassar, and there are several findings, and then I would like to hand it over to Simon to present some more interesting findings on this.
Thank you, Ansariadi, and thank you to the other research team, because what we have is a very interesting set of observations that tend to be not quite similar in some ways. What we find really is the complexity of communication and gaining compliance. It's not a simple thing we're asking people to do. We're asking them to change multiple behaviors that they've never done before, and we're wanting them to do it for a period of time that has no end. And the closest approximation is things like diet. You know, we all know what a healthy diet is, but very few people really follow a healthy diet. And it's the same with COVID. And what we find is the context really matters a lot. So, and Sariadi is mentioning there the issue about where medical and healthcare staff are infected. Is it in the lunchroom, or is it in the ward, or is it in the outpatients? And so there's three different contexts. And so what we tried to explore in our project was how the behavioural models, so we were going back to behavioural science to try and understand if we could get some insight into what makes people more likely to take corrective action. And what's interesting is the sort of key parts of the behavioural models are the perceived severity of the condition, the perceived risk to a person themselves, and also whether they think they can actually take control of their own risk management, so whether they can actually do what they're being asked to do. And I think we heard comments there about the healthcare workers and the differences between hospitals. I mean, it doesn't take much to unsettle somebody's belief system. And so what's interesting is that health literacy is another issue. And of course, healthcare workers are among the highest in the country for health literacy, and yet they're also likely to be infected, and also infected outside of their own workplace. So health literacy alone is not enough. What is often needed is that issue around ensuring that they understand what to apply in which context. The biggest difference we found that it sort of like sits as a moderator of behaviour is that sort of trust and the consistency of messaging. And I think Pak Daniel mentioned the complexity even of the rules and the responses and the services provided by different hospitals was different. And certainly in Makassar, and Sariadi can talk to the confusion and some of the resistance seen by in the community, which leads to a sort of an erosion of trust.
So I think that's a very good point, Simon. And Sariadi, I will get back to you on that, because the work you did in Makassar is very insightful to this issue. I did just want to check in with Pak Daniel and Bu Ratna about where that compliance was occurring. I mean, Simon, you made the message around health. You talked about health literacy. So for Daniel and Ratna, just thinking about healthcare workers, I mean, it seems obvious that you'd have messages up around don't share the same place to eat your food in a break. You know, be careful about which room you're going into, the full PPE gear when you come in and out, which is very exhausting. And from what you've said, people will listen to that message, but it seems to depend on if they believe the hospital that they're working for, and if the hospital is actually implementing those measures so that they can see and trust that they're trying to do the right thing. Now, that's a very general takeaway from what you've said, but is some of what Simon and Sariadi have found resonating with you in your research on healthcare workers?
Yes, that's what we found, Helen. So what we understand from the respondents, basically, and it's very interesting that Simon mentioned about self-risk assessment, because healthcare workers will assess different factors. Number one, how fit they are. And normally when they feel that they're fit and healthy, they're young, okay, there's no comorbid, normally they're ready to take higher risk. Number two is, of course, the area where they work. And it's interesting that we found that one of the critical area or the cluster where COVID transmission actually occur, that is one doctor told us, actually is on the changing room. When the worker has to wear the PPE and took out the PPE and change. That is actually the area where the worker should be protected, but actually become the area that many of the infection actually occur. So that is again the behavioral issue is quite important here. And well, we don't need to mention a lot about where they still congregate in dining room, in other places where they have been told not to do so. But also very, very important is that many of the infection actually occur outside the workplace. And this is interesting part because psychologically, when healthcare workers are in the hospital, especially if they are working on the COVID area, they become more alert, they become more cautious, they become more vigilant. But once they go home and they see that, well, this is no longer a red area or red zone, then they let down the safeguard, and that is where the infection occur. And Ratna can add on it.
Yes, yeah, I think what Pak Daniel mentioned is already covered all our finding. So I just can add a little bit more regarding the area of the hospital where there's potentials that the infections among the medical workers that took place. The other place is in the elevator, and then the other part is in the office. So basically talking about the perception of the risk, yes, generally the medical worker will high their guard. They put their guard very high if they work in spatial room for particularly caring for the COVID-19 patients. But when they go out from that red area, they start to let their guard down. So that's I think it's still an issue. That's why maybe we need to have more policy, or we need to have more like educations more probably for the medical workers to make sure that they still abide all the protocols well.
And not to mention that we need to understand that wearing the hazmat, okay,
Right.
full hazmat in a tropical country like Indonesia for at least 8 hours a day. It's difficult to imagine, right?
Very tiring.
Yeah.
Very tiring. They've done an incredible job over 2 years, and our hearts go out to them. And I imagine if you step out of the hospital and you're perhaps not in Jakarta, which Ansariati and Simon, that was the high health literacy place. That was a place where people were really aware of how they should be safe, very aware of COVID-19 and control measures. But in a place like Makassar, a different story. So you've got perhaps healthcare workers who are trying to do the right thing in hospital, but they're very tired. They need to go home, and they step out into a community that is perhaps acting very differently to what they're trying to do within the hospital. Could you explain to us a bit about what you were finding out in Makassar and what was happening with public opinion there around following health protocol measures?
So yes. All right. Just to add on this, Makassar and Jakarta has a different situation in terms of following the health protocols. Just to give a context, in Makassar, on the early stage of the pandemic, the measure has been replacing for 3 times, and then each of them has actually giving a different message to the community, and that actually influenced the trust to the governments. And then later, the governor also has been replacing during the peak of the pandemic, and then that's chaos in situations influence how the government provide a message, take an action of preventive measures, and it's quite difficult because sometimes it's changed very rapidly. While in Jakarta, actually, it's quite different. What we call the government structure. They have autonomous provinces. So the governor actually has a strong position, a strong authority, and they could control until to the district level. While in South Sulawesi, it's quite different. The government some of the authority could not be directly taken by the governor until the district office. The district office, the Bupati, the Wali Kota has their own autonomy and cannot be intervened by the government for certain situations. And I think that giving a different context and how the people behave in 2 different areas. Probably Simon could also add some information. And also the hospitals. The hospitals belongs to different level of governments. some of the hospitals, particularly for the A level, which is the top referral hospitals, belong to the Ministry of Health. Other hospitals belong to the provincial governments, and other hospitals belong to what you call the at the district level. So sometimes 3 different hospitals belong to a different level of governments, and also they receive a different kind of logistic or supplies for PPE, and they sometimes, you know, provide a different context regarding to the which level of governance you belongs to. Thank you.
Thank you.
Thank you, Simon. I just say there's 10 more layers of complexity here, but help us sift through them.
Yeah, and perhaps that's the single biggest takeaway is the complexity, because even in the study results, you know, I'm just looking at our results, you know, 70% of people in Jakarta identified that they'd been diagnosed with COVID. So that's twice the number compared to Makassar. And yet the risk perception in Makassar was much higher. So the people of Makassar perceived that they were at higher risk. Now, clearly, what's interesting is in Jakarta, the perception of lower risk, even though there's greater experience, which may suggest that they feel like the situation's better controlled. So there's that sense of we're in safe hands, things are working. And you know, I know in Makassar there were a lot more protests. There was a lot of resistance, and so in the results that we have, the attitude towards government and attitude towards what's being requested of people was much lower, much worse. So people resented what they're being asked to do. So what it means really is, I guess, if you're looking to the future, because I mean, none of this is sort of meant to be critical, because I don't think any countries, you know, very few countries have had to go through this experience. And so we're all learning as we go. And as researchers, we're only able to measure, observe, interpret, and suggest. That's our job. But what I find interesting is even comparing the 2 studies, going back to the conversation with Daniel about the health workers feeling empowered, feeling strong that they're not going to be affected. So we talk about self-efficacy. And what's interesting, whenever you measure efficacy, so this is your ability to actually do what you think you're doing, it's often much, much higher than your actual effectiveness. So if we were looking at the use of PPE, your younger doctor's going to say, I'm perfect, I'm protected. But when you actually observe what they do, it's likely to be far less effective. So self-efficacy is an issue on its own because it moderates your likelihood of doing the other things that you've got to do. But it's also the complexity of the context. And we keep coming back to context with, you know, tired healthcare workers who have different lives. They have a life outside work, a life inside work. We saw with our results in Sulawesi, the self-reported activities that people do, which we consider risky. So that's going to the shopping centres, going to families and friends, travelling long distances to visit family, were much higher reported than in Jakarta. Now, I'm not sure why, perhaps and Sariadi or others can explain, but it seems a very stark difference. But we interpret that as a perception of risk and the need to moderate that behaviour. And I guess that's where trust is that funny sort of, it's almost like a modifying dial. It changes the way the risk perception model works. And it's not linear. So in a place like Makassar, a lot of the indicators would suggest people may be better, actually their behaviour should be better than it is that we report, but the trust has actually created a situation where there's a sort of a worse situation than perhaps would have been if we'd had better trust in government. And the trust is not only in government in Makassar, it's also globally. We've had an unprecedented global social media storm of misinformation and anti-vaccine sentiments, and it's a very difficult situation for someone to navigate, even for sort of people with good health literacy. And we see that we've repeated this study in Australia, we've repeated a similar study in the US, and you end up with these really paradoxical results where even literacy matters less in America than your political viewpoint. So you will behave according to your political views more than your health literacy would determine. So it's not straightforward. We didn't see those differences in Indonesia, political viewpoints, religious viewpoints, none of that seemed to make that much of a difference.
Well, we are in a different situation to when your research was conducted, and that is, of course, we now have vaccination available. So I do want to tip into that. But just a reminder that by November 2021, so by November this year, there were more than 2,000 deaths of healthcare workers in Indonesia. And around March at the start of this year, we're sitting at 718, and then we had that Delta surge. And now we're sitting at more than 2,000, 2,066, I think it is. That's a significant number. So clearly more work still needs to be done around keeping people safe. Even if you're vaccinated, I imagine work needs to be done in that area. So perhaps if I go to Daniel and Ibu Ratna first to talk around, what is happening now with vaccination? Is that helping the position of healthcare workers? And then back to you, Pak Ansariadi, to look at that, and Simon to look at that element as well. And does that change behaviour? Is it better or worse? Pak Daniel and then Bu Ratna.
Oh, okay. Well, I'll give Bu Ratna opportunity to explain more about vaccine because he's got the latest data. But
oh, excellent. Yep.
Yeah, but just to put in context, right? Indonesia, according to the data from WHO in 2017, Indonesia's ratio between the population and the healthcare workers is not really great. We only have 4 doctors. Indonesia only 4 doctors every 10,000 people in the population. Very, very low, right? Then if you then suffer the casualties from the healthcare workers, every single casualty for healthcare workers, actually it reduces the ratio or makes the ratio actually worse, right? And as you mentioned earlier, Helen, that around 600 casualties until December 2020, okay, between March 20 and December 20, around 9 months. But from December until now, it's until November is 2,000. So it's more than 3 times during the last 12 months compared to the first 9 months of the COVID. So it's really, really, really severe condition. But my last point for handing over to Ratna is this, that we need to protect workers from 3 things. Number 1, from the infection itself, exposure to the virus infection. Number 2, from their physical fatigue, because it will seriously affect their effectiveness in providing the health services. But number 3, also protect them from the mental and psychological fatigue. So these 3, from the COVID itself, from the physical fatigue, and from the mental fatigue. And vaccine perhaps is only address 1/3 of these 3 problems that we need to take care. So Ratna can explain more about the vaccine. Thank you.
It's a good point.
Yes, thank you very much. Thank you very much, Pak Daniel and Helen. Yes, yes. Based on the, fortunately, there's a database that can be accessed by public about how the vaccinations program by the government already conducted so far, and they have the spatial data for the medical workers. And maybe you can access to vaccine.kemkes.go.id, and based on the data, we can see that actually the target, based on the target about 1.4 million, actually among the targeted number actually is already covered more than 100%. Like they already cover for vaccine for doses 1 and doses 2, and some around 80% regarding the latest statistic, they already cover for the booster, for the third vaccinations for the medical workers. So basically about the distributions of the vaccine among the medical workers actually is, we can say, is really well. But yeah, that's the fact. As Pak Adela mentioned, that actually maybe this is only 1/3 of the about the whole problem. Vaccination is can only address some of the problem. We still need to take care of another big issues regarding about the workload and so on. Because if we see further about this, the statistic, the fluctuations, number of fatalities among the medical workers, actually following the number of the infection rates in public. So if we can see also from the statistic, actually it surged, the fatalities among the medical workers surged around July 2020. So that's when the Delta came. So yeah, I think that's the fact that we found during this study.
That's really good. Thank you for that information. That helps a lot with framing it. And look, I will just mention we have a question in the Q&A, which I think the researchers could jump on. It's around the role of unions in the healthcare system in Indonesia. Now, I know a little bit about the industrial system, but not specifically unions in the healthcare system. So if one of the researchers could perhaps have a look at that. While I go, though, to Simon and Sariadi to talk about vaccination. I mean, vaccination is about trust, clearly, and we can see how well that plays out in some areas or not. But how do you think now having a vaccination is changing the conversation around public safety, and is it changing it in a better way?
Yes, Simon, you go first because there is no background. You can go first.
Okay, so I think the vaccine, it is definitely helping. I guess, as you say, our results show intention to vaccinate, and clearly that follows the same sentiment as the intention to comply with COVID safe behaviours. So Jakarta has a higher compliance intention for vaccination. I think personally what I see is a slightly increased amount of confusion, because people are certainly in Australia we had the confusion around the types of vaccinations and the potential adverse events. I'm not sure what's happened in Indonesia with that, but there's certainly a much more complex situation there with a larger range of vaccines available, some of which are not as universally accepted as, with different levels of effectiveness or efficacy. I think vaccination just adds to another problem in terms of communication, because the vaccination itself is not as simple as, say, a measles vaccination for a child. It's not a simple vaccination because it doesn't have a simple endpoint. People can still be infected, they can still develop symptoms, they can still develop severe disease, even though they're vaccinated. And so it adds another layer of trust issues, because you then have the trust in the vaccine and the fact that the government's providing it is all linked. What it shows us really is the really, really important part, that building a stable platform of communication and trust, why it matters so much. Very hard to build, very easy to lose. I'll hand back to Ansariadi.
Yeah.
Thanks, Simon.
Very easy to lose. I think that's a good point. Yes, Ansariadi.
Simon, we conducted this study before the second peak of Delta on June and August in Indonesia, and I think the situation during the July and August, where number of cases the highest in Indonesia, also provide a different perception to the community. Some of the people could see the worst situation during the time, because in the messages we could find there's a report that the 26 patients died at the hospital one day, because they couldn't afford the oxygens. And then the messages spread out all Indonesians populations. So I think the situation in Indonesia now has changed a lot. This can be seen from the uptake of vaccination, for instance, where in Makassar, I give an example in Makassar, the coverage of vaccination now has been doubled in last 2 months. Yes, more people become aware about the vaccination, but still lower coverage among the elderly people over 65 ages. So we see some improvement in terms of vaccine coverage, compliance to the health protocols. But still there's a discrepancies among age group. For instance, the uptake of vaccination among elder people. But there's still an issue about the trust to vaccination, because people now become aware whether the vaccine is effective to stop the transmission, as it happens now in Europe, where people 85% of the population has been vaccinated, but number of cases has been increasing in the last few weeks. So many people asking again whether the initial message from the government say that vaccination could prevent you to get infections. But what the fact that we got from the situation in Europe is that the vaccination may not stopping us to get infection, but prevent us to get a severe situation. So the message now has changed, that the vaccinations protects you to get a severe situation once you get infection from COVID-19.
Okay. Yes. Look, sadly, we have to leave it there. I would like to talk about this a lot more. There's so much more ground to cover around how humans respond to messaging, the challenges ahead for the healthcare workers and getting the help that they need after being through a particularly grueling 2 years. But at least we've started the conversation. And of course, the work that you've done is available at the Australia-Indonesia Centre website, or about to be made available, particularly on the Partnership for Australia-Indonesia research part of the website. We will be providing information after this webinar as well. So if you're on our mailing list, then you will stay updated and learn more about the great work that these two research teams have done. So thank you very much for your time today and for providing us with your insights. It's very much appreciated. I'd like to thank Professor Daniel Prayogo, who's the COVID-19 research co-lead at the University of Melbourne, Dr. Ratnasari Dewi, who is also a COVID-19 research co-lead at Institute Technology 10 November, Associate Professor Ansariadi Ancha, COVID-19 research co-lead Universitas Hasanuddin, and Associate Professor Simon Reid, COVID-19 research co-lead at the University of Queensland. And what a fabulous list of universities that is, just to give you some idea of the collaborative work that is done between the two countries. Well, now to bring all that together for us, it is my absolute delight to introduce John Lee, who is the team leader at the Health Security Partnership. And our two sessions today around data and the healthcare systems and workers and messaging is something that he is very much across in his role. So thank you very much, John, for being available. And if we could now hear your thoughts on what we've learned today and what we can take out of it.
Great, thank you very much, Helen. And this has been really a very interesting couple of sessions. And indeed, where to start? I have just a few minutes to try and discuss some very different issues. So let's just, first of all, echoing what Helen said, to appreciate, the collaboration between different universities. We first had in the first session the collaboration between University of Melbourne and the Universitas Gadjah Mada, and then just now we've been hearing about the other partnerships between 10 November and Monash, You know, that's really interesting, as well as with Hasanuddin and University of Queensland. So let's start with the data connectivity and integration. As was seen in this study, there are multiple systems in operation that don't really communicate with each other. Some of our own work that we have done in the Australia-Indonesia partnership has basically found the same thing. We have looked at the different levels of the system across a number of different provinces. And we found, for instance, that in the puskesmas, in the primary healthcare centers, there are 77 different data applications that are being used. There is no interoperability between them. There is no prioritization amongst them. It is all based on different kinds of demands of vertical programs. So you can imagine the people who are already pretty overworked at the puskesmas and now additionally overwhelmed with the burden produced by COVID-19, and still having to input data into 77 different systems, often having the same data entered multiple times into different systems. Similarly, at district hospitals, they have 55 different data applications operational. At the Ministry of Health, they have hundreds of data systems. So there's obviously huge duplication of effort. And we have heard from the presentation that you can't easily access the data that you need, and it's very slow. So then people go to find a workaround using WhatsApp or you know, other non-standard applications. So obviously there's a requirement for interoperable systems, as has been recommended by the study. I think one of the most important things will be to move away from a program-based mentality to an individual-based or person-based mentality. So one patient presents, that is a person, and you have a data record that is associated with that person. Instead of seeing a person as just one of the statistics in a malaria program, or one of the statistics for COVID-19, or one of the statistics for TB program, or whatever it may be, we treat the people as individuals, and we have the data connected to that individual. I think we need to bear in mind, as was brought up in the discussion, particularly by Pak Petra, that there are huge varieties across the country. And when we're designing an interoperable system using some good interoperability standards, for instance, HL7 FHIR, FHIR, which is now being introduced into the Digital Transformation Office in the Ministry of Health. The capacity of the IT infrastructure in different parts of the country has to be also borne in mind. I mean, nowadays we are all living on Zoom, right? And sometimes I have Zoom conversations with people in different parts of the country, and they get cut off because of the poor internet connectivity. So, you know, we have to bear in mind that the connectivity might not be that great in some places. And so systems have to be designed in a way that can get around that. There are different ways of doing that. You can have apps that sit on devices that store the information and only upload it to the system when they have good connectivity, but they are not dependent on being online 100% of the time. There are lots of ways around this, but we need to look into those issues. You know, COVID has presented a fantastic opportunity, as the minister said in his opening remarks. Great crisis presents great opportunity. We can solve some of the issues with digital technology, that is for sure. And there's a great opportunity, I think the opportunity of a generation to really transform some of the health systems. And obviously, as we have also heard from Pak Jeff and from others, there is, you know, huge willingness to collaborate between Australia and Indonesia in bringing those systems up to the next generation to be fit for purpose. And there is a young generation in Indonesia that are extremely literate with these new technologies, more than the older generation, and I would venture to say much more so than Australians in general. I think there is huge capacity in Indonesia to take a leap forward in terms of the technologies that are being used, bearing in mind my earlier comment about the infrastructure that needs to be in place. But at the bottom of it all, there's the human capacity. You know, we can do lots with technology, we can invest more in systems and so on, but there has to be the human capacity. And I think it's not only about whether people are able to use systems. I think generally now with the younger generation, people are very much able to use the systems. The issue is whether the system is useful to them. And I think this is a question that we haven't really looked at in depth during these discussions today, but I would say that this is really, really important. Making the data useful to the people who are putting the data in. Otherwise, I'm sure everybody is familiar with the expression GIGO, right? Garbage in, garbage out. When people don't have the time, when people are overworked, as we heard from the other studies, when people don't see the benefit that the data has to them, there is a tendency to just rush it, put in partial data, incomplete data, or maybe no data at all. So the data has to be made useful. There has to be feedback system. There have to be dashboards or other things that can be developed that they can use at the facility level, whether it's a puskesmas, whether it's a district hospital, whether it's a private clinic, that they find that the data is useful and that they can use it to monitor their own work, to improve their own work, and to compare their work with others. You can have peer-to-peer comparison between different facilities. And we also talked briefly about, you know, the resistance to change. And I think that is something we always have to deal with in any kind of change process. It's part of human nature. But if people see that having good data and being able to analyze that data for myself at my facility and seeing what it means for me, they will see that as a positive development and they will support that change. So moving on, we talked also about the other studies. So two quite related but different topics of protecting healthcare workers and also changing public attitudes. I think in terms of protecting healthcare workers, there are a number of factors that have been brought out. One of them is the whole issue of health literacy and education, which is important and has to be stressed, but is not sufficient in itself. It's a prerequisite, but you have to have more than that. We heard about trust, for example. I think there are also important management issues that have been brought out by the report. Some of them include making PPE equipment available, for instance. Maybe lack of budget has been an issue. You know, making sure that the money and the resources get to the right place, making sure that standard operating procedures are complied with and so on. That's a management and that's a supervision issue. So that needs attention. But I think most important of all, which has been brought out by this report, is the mental and emotional well-being of the healthcare workers. We are demanding a lot of them. And very often they have to suffer a lot. You know, the general public, unfortunately, and this is not just in Indonesia, it happens in Australia, it happens around the world, the general public is often not very nice to those people who are serving them, those health providers who are selflessly serving them. So we need to be able to make sure that whatever supervision and management is in place is highly supportive. Right? We know that these people are going to have to work long hours. We know that these people are going to be incredibly stressed, but we need to make sure that they are constantly reaffirmed in their role, that there is a positive management culture that encourages people and thereby motivates them to do the best job and to take care of themselves and their families, so that they don't let down their guard when they go and change their PPE equipment, when they go and sit with colleagues and to have a lunch, when they go home to their families, that they recognize that they have a responsibility to protect themselves, to protect others, to protect their families, and that will be greatly helped by much more positive affirmation of those people. In terms of changing public attitudes, We've also been doing some tracking of public attitudes, at least in some of the provinces. I think it's one of the positive things is that it comes out universally in all of the studies that people actually still trust the government. People trust government doctors, government experts. They come out as number one in terms of the people trusting. What source of information do you trust? Right? They don't necessarily trust family members or so-called social influencers, but they do trust the experts. And that's great, because that is something that Indonesia has, which unfortunately some countries don't have now. There's a great sort of skepticism around the world about experts. But I think in Indonesia, we still have that. As has also been pointed out, there isn't the politicization, say, of mask wearing or getting vaccinated. Those are not there in Indonesia. What we found from our studies is that the number one reason for vaccine hesitancy is people are not sure about the side effects, what is known as KIPI, right? The adverse symptoms, adverse effects after a vaccination, or people are not, as has also been mentioned, quite confident that the vaccine is going to work. And what we are seeing from the latest statistics is that the rate of vaccination, although it is still going up, has slightly slowed down. So people may be becoming a little complacent because of the fact that there are not so many cases around. So it just shows that we really have to continue to work on generating trust, to be open, to be transparent, to really state clearly what the risks are. Sometimes people kind of don't quite trust the government because the government is always very positive. There are also risks. There are negative things that also need to be communicated. People do believe the government experts, but they need to hear the full story, not just some kind of sanitized version of the story. So I think, we're still all learning. And going back again to what the minister said, the first thing today, this is a great opportunity for change. Let's learn from COVID. Let's apply the lessons that are learned to the whole health system, not just to dealing with COVID, but to dealing with all other diseases and all the other conditions that the health services have to deal with on a day-to-day basis. That we can support our health workers, we can give the best possible tools to them, that we can encourage them with positive and affirmational management systems. And hopefully next time we have a nasty pandemic coming around, which unfortunately is probably going to be the case, we will be better prepared. And certainly Australia and Indonesia stand together in partnership to see that this research and these findings are going to be applied and are going to enable us to learn from one another. As Jeff said earlier, it's not just a one-way traffic, it's about a partnership, it's about us learning from one another. So I think that's all I wanted to say. Thank you very much. I'll pass back to Helen.
Thank you, John. That was a fantastic wrap-up, much appreciated, and some really good extra points we learned in your discussant role. So we do appreciate your time. Thank you so much. And now to close the session, I would like to invite Kirsten Bishop, who's the Minister Councillor for Governance and Human Development at the Australian Embassy in Jakarta, who also kindly is giving us her time today to provide some closing remarks. Thank you, and lovely to meet you, even if just virtually for the time being.
Thank you very much, Helen, and selamat siang semuanya. My name is Kirsten Bishop. I'm the Minister Councillor for Governance and Human Development here at the Australian Embassy in Jakarta. I'm really very pleased to be joining you all this morning at the second AIC Paris Summit, and in particular to be able to close the session for today, which has involved so many impressive speakers and participants. As you know, the theme of the event, COVID-19, improving healthcare, protecting society and economic recovery, comes, of course, at a time when both our countries, Australia and Indonesia, are taking steps to return to a new normal as the pandemic continues to evolve around us. But the conversations we are having are important and help us to ensure that learning, as we've just heard, learning from our experience during this pandemic is not lost and will inform how we move forward. This event has been a real showcase of the best of the kind of relationships that we have between Australia and Indonesia, and we can see how our networks are supporting each other, sharing knowledge and innovation, and trying to find together solutions to what are ultimately shared challenges. Today we've heard about the theme of improving healthcare, and we know that both Australia and Indonesia have learned some hard lessons over the last year and a half about some of the gaps and challenges in our respective healthcare systems. And we've also both grappled with shortages of healthcare workers and personal protective equipment, and our data systems have had to be agile and innovative in trying to report cases and understand high risk areas and issues of that kind. And sadly as well, we know that as we've just heard, Indonesia has suffered some of the highest rates among healthcare workers, rates of deaths among healthcare workers from COVID-19 in the world. So during these, what are very difficult times, I think we are very fortunate that the strong ties between Australia and Indonesia mean we're in a very good position to share knowledge with each other and to collaborate together to find solutions. And the Australian government continues to work very closely with our Indonesian counterparts to support Indonesia's COVID-19 response, including support to local health systems with equipment and ongoing training efforts and provision of essential goods, and also delivery of COVID-19 vaccine doses. And also our Australia-Indonesia Health Security Partnership has played a really vital role in helping Indonesia respond to both its immediate needs in the face of the pandemic, but while also working closely with Indonesia on some of the longer term objectives around building stronger health security systems in Indonesia, working on issues of surveillance, laboratory capacity, human resource capabilities, which which are so important. We know from our experience over the last 2 years, but also into the future. And also we continue to work, of course, closely through our multilateral health partners and Indonesia's multilateral health partners to maintain some of those other key services, health services that are combating other conditions like measles, polio, malaria, TB, but also ensuring that there's access to safe maternal health care, family planning and other critical services throughout the pandemic and beyond. So turning to just to AIC PAIR's COVID-19 rapid research projects, which have been conducted by our partners through the PAIR initiative and funded by the Australian government. I think it's been really an impressive demonstration of the ability of our partners to really pivot and respond to what has been an urgent crisis. And the findings of these projects, as we've heard through today, have been very timely and informative and are really already feeding into help policymakers tackle some of these current urgent challenges, and also helping us though to prepare for the future. And unfortunately, we know that crises of this kind will continue to occur into the future. So I just really wanted to commend and thank all of the AIC PAIR researchers who have been involved in these research initiatives, and particularly those who we have heard from today. And looking to today, in particular, the theme of the first session around health data and connectivity, health data connectivity and integration. We know that Indonesia, as we've heard, has such a huge and dispersed population, and a decentralized system of government makes data integration and connectivity a particular challenge at the best of times, and no less throughout a pandemic. And as we all know, the Indonesian government recognises, and before the pandemic has recognised this challenge in the launch of Satu Data, the Satu Data Indonesia initiative. And Australia is pleased to be supporting that initiative in a range of ways, including in the health sector through some of these really important research partnerships that are really working to better understand the nature of these challenges and to inform policy and also the development of practical solutions to those challenges. So we've heard from our researchers today, Associate Professor Shira Kurnia and Dr. Safirotul Kaur, who presented on their study on data integration in Yogyakarta during COVID-19 and their recommendations to adopt an open health information exchange framework, create a national standard for data capture and develop stronger systems for the future, including around data protection, are all extremely valuable in informing policy, the important policymakers and program decisions into the future. And the perspectives of industry leaders like Jeff Parker, Pak Jeff from the Australia-Indonesia Business Council's Health Group, but also Pak Petra Kareti from Pulse Lab Jakarta, also very insightful. And we know that there are certainly, we think, further opportunities for Indonesia and Australian health sector businesses and other partners to collaborate together in this area, as outlined in Australia's recently launched Blueprint for Trade and Investment with Indonesia, which specifically highlights digital health as a key area of collaboration and cooperation into the future. And lastly, just turning to the second session this morning on protecting healthcare workers and changing public attitudes. As we know and as we've heard, healthcare workers, of course, are at the front line, have been at the front line of the COVID-19 pandemic, and have really had to work hard and to maintain their physical and psychological well-being, and have been under a lot of strain. And occupational health and safety policies are so crucial in supporting these workers. And the work of Professor Daniel Prajogo and Professor Ratna Saridewi and their teams provide such meaningful recommendations in terms of how these practices and policies can be improved. And at the same time, the public has also been required to adapt how they live and how they adapt to public health guidelines and protocols. So in that regard, Associate Professor Simon Reid and Associate Professor Ansariadi Ansha have also, of course, discussed how rates of education, literacy, and trust in government can impact on individuals' behaviour and compliance with these kind of protocols and regulations. And of course, the more we can understand the complexities of these motivations, the better we'll be in future to be able to respond and communicate effectively on public health and crisis response. And finally, just to say a big thank you as well. It was great to hear from Pak John Lee, the team leader from our Australia-Indonesia Health Security Partnership, who did such a great job in bringing together some of the key themes and the key issues from this morning's sessions. So in closing, I would just like once again to say thank you very much to AIC PAIR for putting together this summit once again this year, and to thank you to all the AIC PAIR researchers whose expertise, hard work and passion have really helped us to illuminate what are very difficult and complex policy issues over what has been such a dark and difficult time for all of us. So thank you once again. Selamat siang and salam sehat.
Thank you, Kirsten Bishop. Salamat siang to you as well. That is Kirsten Bishop, who is the Minister Councillor for Governance and Human Development at the Australian Embassy in Jakarta, rounding off our Day 1 Summit presentations. Thank you so much for joining us. I hope you found it useful and interesting. And as I said earlier, we have information on our website about all those research projects. Now, we of course have 2 more days to go, not one after each other, so you do get a break. The next 2 sessions are going to be on the 2nd of December, which is this Thursday, and then the next 2 after that are on the following Tuesday, the 7th of December. I was momentarily bamboozled by that fantastic slide you can see in front of you. Outlining the speakers for each of the 2 days remaining, and also giving you a QR code so that you can easily register for those events. This Thursday, we're going to have some great conversation around the creative economy and also disability and how they've been affected by COVID-19, and also some solutions to help people move forward. And then next Tuesday, we're going to talk about health versus economy, a very tough decision, and also the impact on the tourism industry of COVID-19, which has been pretty obvious to see, but the researchers have done some great work in drilling down into it. So please come along and join us for those sessions. Today's webinar will be available on demand as soon as possible, as soon as we can get the technicalities sorted. And you can find those recordings and much more on the PAIR website. And we'll post a link in the chat for you to take you to that website. There's also an extremely short survey at the close of this webinar, and we encourage you to complete it. We do know that we've taken up your time. We love having you with us. If you can do that short survey, that would be wonderful. I would like to thank our Indonesian Sign Language interpreters, Pak Widodo and Bu Sonia from Insali, who've done a wonderful job for our audience, and also our audio translators, Langua, who are our fabulous partners for these events. Thank you again for your time. I hope you have a wonderful rest of the day and that we look forward to joining you again on Thursday.